I think what we had done as a board, to the best of our ability, hired an administrator to replace Bill. What we were looking at that point in time is healthcare was changing, and so we knew we had to basically have an administrator that was going to be that change agent. What we ended up with, though, was really a disruptor.
In the 80 years since Perry Memorial Hospital had opened, the organization had never experienced a year like 1999. After 2 decades of growth, the leadership was wiped away, along with trust and stability. Financially, the hospital had started the year like normal, with a profit. By the end of 1999, that was no longer the case. Under the new CEO, departments that were not showing a profit were closed, and problems with overstaffing were resolved quickly.
We had clinics in Lamoille, Ohio, Walnut, Manlius, Henry, Sheffield. We had clinics in all these different places, We'd hired a lot of people to staff them. And really about the first thing that happened was they closed all those clinics.
After dozens of letters, daily phone calls, and even public demonstrations, the hospital board had to get directly involved.
We ended up having focus groups with employees to work through problems and issues. And in the end, the resolution was that as a board we had to change direction.
Later that year, the board voted to remove the CEO and regroup.
Greg Davis and Dennis Van Ortstrand really graciously stepped up and said they would run the hospital for a while. And I think the hospital owes its existence to those two guys. I think there was a real danger of employees walking out. It was just a mess, and they brought stability to the whole thing, calming everybody down, saying, we're going to get through this, and they did.
The year 2000 marked the first time in the United States that the number of people with the internet would surpass the number of people without. Only 10 years before, less than 1% of the population had access to the World Wide Web. The digital revolution was just beginning. Just as phones and cars had transformed the quality of healthcare decades before, computers were starting to do the same. Laboratories could process more tests far more quickly. New equipment made it possible for clearer X-rays and CT scans. Not only could doctors receive better results sooner, they could communicate with specialists much more easily. On the other hand, digital technology was expensive, and each new version became obsolete quickly. Businesses could invest the money for the latest, most up-to-date technology, and in a matter of years, or even months, it would be behind the times once again. Without the high inpatient volume of the 1980s, small rural hospitals lacked the revenue to invest in the latest technology every year, on top of their other facility expenses. Perry Memorial Hospital was facing the same challenge, on top of resolving the problems created in 1999. In their short stint as volunteer administrators, Dr. Davis and Mr. Van Ortstrand quickly and successfully stabilized the hospital.
Dr. Davis was on the board, and Dennis Van Ortstrand were on the board, and they stepped up to jointly manage or administer the hospital while the search was going on.
The following year, the board hired Robert Seneff to permanently take over.
And Bob was had a calming effect on the hospital, its employees. He was very hands-on, a visionary, and and earn people's confidence.
Bob was a local boy and grew up through the system here. And what I remember most about him, he was very physician-friendly. Got along well with physicians, encouraged them, helped them.
Bob Seneff understood the model of rural healthcare was changing. The cost of services was continuing to rise, and the wealth of the county was dropping. With a population of predominantly Medicare and Medicaid patients, the hospital was stuck in survival mode, and a few bad years could mean the end of Perry Memorial Hospital.
It's very difficult with our patient population and their what we call payer mix. If you don't have enough high-paying customers versus public aid, Medicare, which are very low reimbursement, you simply can't pay the bills.
They had to find a way to increase revenue within a system built to keep reimbursement rates low. The solution came in the form of a new federal program, established as part of the Balanced Budget Act of 1997. The federal government established a program of critical access hospitals in an effort to prevent rural hospitals from closing. Hospitals designated as critical access would receive 101% reimbursements for Medicare patients. In other words, those hospitals would no longer lose money from Medicare.
They were going to start paying services in a slightly different way in order to, in essence, subsidize small rural community hospitals who couldn't financially make it under the old system.
For Illinois, the Critical Access Hospital program kicked off in 1999 under the leadership of Princeton native Pat Scow.
Pat was our vice president of nursing at the hospital, and she's one of the people that got fired. And when she left Perry, she went to work for the Department of Public Health and literally designed the critical access program in Illinois. There's a few towns in southern Illinois I can take you to that if it weren't for Pat, they wouldn't have a hospital today. She just saved the day in a lot of these little towns.
The following year, Bob Seneff and the board led Perry Memorial Hospital in becoming a critical access hospital. Perry Memorial Hospital had to meet certain criteria. There could not be more than 25 beds, and the emergency room had to be staffed 24/7.
We were looking at trend information and knew that outpatient was increasing, inpatient decreasing. And our last plot or data point on that trend was it fit perfectly with critical access in the 25-bed minimum. Our drive or objective from the board perspective was to maintain all the services that we currently had, except that what we wanted to do is just fall under a different payment scheme, which would be critical access and it would be cost plus 1%. And we looked at that as a way to help salvage the bottom line at the time, which it did.
Throughout the 1990s and 2000s, the ER was becoming a more popular choice for the community, despite the high prices of ER services. ER visits were on the rise all across the country.
Emergency room used to be staffed by local practitioners on an on-call basis. Over the years, that's evolved to 24-hour physician in-house staff. And the volume has increased dramatically, probably doubled over the last 15, 20 years. There's more tests being ordered, more expensive tests being ordered. So I think the expense has gone up. The emergency room is now staffed by board-certified emergency room physicians instead of local practitioners. That's more expensive. So the expense for the ER has increased year after year after year, more so than the expense in the rest of the hospital.
As the need for the emergency room increased, so did the demands on the laboratory and radiology departments. The latest equipment was becoming bigger and better, but the space available in the 1969 hospital was small and outdated.
When I left in '99, I think we had $13 million in the bank. That's what we wanted to do, was start building some money, because we knew we needed to have a major building program at some point. And Bob Seneff came along later and did it, and bless his heart,
In 2005, Bob Seneff leveraged the hospital foundation, along with bonds and the saved revenue from the 80s and 90s. to pursue a new expansion and renovation project. Healthcare had already shifted to outpatient, and the construction project would bring Perry Memorial Hospital's outpatient services into the 21st century.
I don't think we really increased what we were doing. We just needed more space to keep up with technological advances. The emergency room needed updated because it was small, outdated. We were seeing increased volume, and we went to 24-hour physician staffing.
With the project well underway, Mr. Seneff resigned in 2006. The board hired a man named Rex Conger to take over the project and leadership of the hospital.
Rex Conger was very by the book. He had a military background, did a good job running a tight ship.
Rex, again, maintained that element of stability.
Between 2005 and 2009, the back of the hospital was significantly expanded, and the building's 40-year-old main entrance was given a facelift.
The renovations between up through 2009 were made possible by a capital campaign, and it was really very, very well supported by the community.
The next challenge would come in 2010 with the Affordable Care Act. The new law was a sweeping overhaul of healthcare regulation and coverage, the most significant since the creation of Medicare and Medicaid in 1965. For hospitals, the Affordable Care Act meant new compliance and quality expectations.
It became also a cost-driven quality initiative also, and that if you didn't meet certain quality requirements, you would not benefit from government subsidies and programs.
There were more steps to prove that quality care was being given. New digital technologies continued to roll out throughout the 2000s, and along with it, a greater ability to avoid mistakes. Electronic systems were becoming faster and more accurate. Computer software and medical devices were being made with built-in safety features to prevent accidents. The Affordable Care Act pushed hospitals to embrace the emerging technology.
Well, technology makes it easier to diagnose based upon some MRI and CAT scans. It just tells you what's wrong rather than making your best guess. Technology has made it much easier for the rapid dissemination of information. There's nothing new at the Mayo Clinic that we don't know tomorrow. It's all there for the asking. So everyone knows everything at the same time. There's no place where you can go to get better care based upon the fact that they know something you don't. Now, the downside of technology is the time it takes to input data.
As part of the new law, hospitals were required to adopt electronic medical records to replace the old paper and pencil patient files.
I took a chart and looked at it when I first came in one time that a doctor had done. I read his chart, right upper quadrant pain, diagnosis, cholecystectomy, gallbladder, procedure, taking the gallbladder out. That was the chart. Last one I went in, they had a stack, I think, of about 6 pages.
When I was at my busiest, it was nothing to see 35 patients. Now, if I saw 35 patients today, I would be in the office till midnight, cleaning up the charts because of everything you got to put in there. You got to be so careful because you know what you did for that patient. And you know what you're doing for that patient. But nobody's going to look at that patient. They're going to look at your chart. Lawyers are going to look at your chart. Auditors are going to look at your chart. Insurance companies are going to look at your chart.
Throughout the 2000s and 2010s, coding and reimbursements would continue to become more complex and challenging. In 2011, sequestration became a way for the federal government to save money on Medicare by reimbursing 99% of costs instead of 101. Once again, Medicare would cause hospitals to lose money. The other outcome of the Affordable Care Act was Medicaid expansion. Suddenly, millions more people qualified for Medicaid, which paid less than half of what it cost hospitals to provide the services. Hospitals were left footing the bill for many expensive visits. one area where Medicaid hit hardest was obstetrics. The 1980s and 1990s had seen a high volume of childbirth. By 2010, the number of births in Princeton had dropped by more than 75%.
You have to look at our county. Our county used to have a high school in Walnut and Manlius and Wyanett and Tisquewaw, and those are all gone now. The baby boom is over. The demographics are against these rural communities, and not just this one.
At Perry, you just didn't have the volume of it to offset what it should be. You have to put 3 nurses a day, just to have one patient there. You'd have to have one available if there were no patients there. And then the delivery room, it's expensive, And out of that, whoever came in would be, at that time, 50% wouldn't pay or have the state pay. They just walk in, have the baby, and
By the 2010s, Medicaid accounted for half of all births in rural hospitals. Rural hospitals across the country opted to end the service. In 2013, Perry Memorial Hospital did the same. Although the demand for services like obstetrics was diminishing, other outpatient services were growing. The Affordable Care Act was pushing the reliance on primary care. For hospitals, primary care was the gateway to other services. In 2014, CEO Rex Conger began discussions with Princeton family physicians and made a deal for Perry Memorial Hospital to assume ownership. For the first time, the hospital would employ and manage physicians directly.
There was planned turnover at Princeton Family Physicians, and we, at that time, really did not want to assume the risk of losing our physician, our primary care physician base. And really that's what led to the decision to purchase that. Again, at the same time, you have a national trend that is moving away from the independent practitioner to employed physicians.
You need to have providers in the area that are feeding your hospital and the other departments, outpatient departments, plus the subspecialties. Without that, you can't exist. It came at a time when most physicians graduating from medical school did not want to take the financial risk of opening their own office. By employing physicians and nurse practitioners in primary care settings, the hospital is providing access to care without counting on physicians to do it themselves, which less than 10% of the new graduates will ever even try to open up on their own.
I was the last generation who was able to come out and start a practice, be independent of the government, the hospital, health systems. That's gone. That has been eliminated.
In my latter years there, we were spending a couple $100,000 a year trying to recruit doctors. For a small hospital, it's like an ongoing thing.
With the new family health clinic, Perry Memorial Hospital could now leverage an established and well-reputed practice to recruit a fresh team of physicians and nurse practitioners. 2 years later, the hospital also entered the arena of urgent care. Perry Memorial Hospital acquired Princeton Prompt Care in 2016. That same year, Rex Conger retired as CEO after 10 years.
And of course, that's where Annette Schnabel was our next administrator.
She would carry forward the idea of clinic expansion at an even faster pace. Over the subsequent years, the hospital would acquire or open 6 other clinics. Rural clinics were reestablished in Henry and Walnut.
It's a matter of having a presence in an area to assure your patient base and population.
In 2020, Perry Memorial Hospital opened a new family health clinic facility across the street to offer an updated and accessible space with room for growth. The competition of healthcare was increasing quickly. People were becoming accustomed to traveling for leisure and now also for medical services.
Perry's geography, it is surrounded by other communities with hospitals. And they obviously have an eye on you at all times, wanting to see if they can take a few of those patients. So you're always in that sort of game too, trying to keep your own patient.
Hospitals were forced to compete with each other for patients, and technology was allowing billion-dollar corporations to join the healthcare industry too. Companies like CVS, Walmart, and Amazon were starting to find ways to offer healthcare services and products at a lower cost and greater convenience. With tablets and smartphones, the average person now had access to an abundance of medical knowledge at their fingertips. Perry Memorial Hospital had faced a shrinking community since it opened in 1920, and now technology was luring even more people away. After a series of educational meetings, Annette Schnabel and the hospital board had a better understanding of where healthcare was going.
We need to move in a direction where we were advocating change. Again, as dictated by the healthcare environment. We had a desire to get out in front of that.
Between 2010 and 2019, 102 rural hospitals in the United States closed. It was becoming more and more difficult for small hospitals to balance the volume of patients with the staff needed to support them. At Perry Memorial Hospital, the percentage of commercially insured patients was dropping and dragging down the bottom line with it.
Okay, we were keeping our head above water, but again, you have to understand the environment is one of driving costs down. You're having to invest in technology. It's really to drive that volume, drive that element of quality, and to do that, one of your answers has to be you've got to look at consolidation, especially when you're a catchment area that we're in of 20 to 25,000 patients. You got to find a way to drive that volume to be able to survive.
In 2019, the board began to consider a partnership with a larger hospital.
And Annette was very instrumental, at driving that change and put us in a position where we can have conversations about management agreements and about affiliation and have some degree of leverage. We did not want to wait until it was too late and we'd be desperate to affiliate. And it was the latter half of 2019 where we entered into an agreement or a letter of intent with OSF out of Peoria.
The affiliation with OSF Healthcare dated back to the 1980s, when services and physicians in Peoria became more specialized and helicopters made it possible to transfer patients more quickly. By 2020, OSF had grown to include 12 other hospitals across the state.
They're a force in the area that has to be reckoned with. If it's done right, and we can capitalize by utilizing their subspecialties in our area through telemedicine or clinics on site, then I think it'll be a good thing in the long run.
We could survive as an independent hospital. The question would be, is when do we run out of track? And we have to make that jump. If you look at technology's not cheap. We need to update and maintain this building. Some of its systems internally, from an operations perspective, are very old. How much of that can you continue to finance and run on before all of a sudden you are upside down? That was, again, that vision that we had. We wanted to look out beyond that and make a decision today that is going to provide for this community well into the future. We've been here for 100 years. We want to be here for another.